Neil is a longtime member of Temple Sholom and founder of Pollock Clinics. He is recognized as an innovator, a committed teacher, and leading global authority in his surgical field of expertise. For many of us, he is also known as the Mohel who conducted the bris for our sons. For over 27 years, Neil has been operating Pollock Clinics, which is one of Canada's most recognized men's sexual health clinics, and today is one of the country's leading providers of circumcision, vasectomy, frenulectomy, sorry, and now men's sexual health with a focus on erectile dysfunction treatments. Neil developed his own unique technique for circumcision in newborns, children, adolescents, and adults, which has been taught, published, and referenced worldwide today as the Pollock Technique. Over 1 million procedures using the Pollock Technique have been carried out throughout the world. He is also founder of Gentle Procedures Clinics, which is highly successful medical surgical franchise company, and his clinics have now grown to 25 sites in 5 countries, and continued expansion is ongoing. Neil is also a clinical instructor with the University of British Columbia, Faculty of Medicine. Our other presenter tonight, Dr. Roozbeh Ahmadi, is an associate physician at Pollock Clinics. He completed his medical studies at the University of British Columbia, and his specialization is in family medicine. Dr. Ahmadi is highly interested in complex chronic disease and has completed intensive training at Steinberg Urology Center in Montreal on the various testing and diagnosis methods for erectile dysfunction. In addition, he has also participated in educational sessions at Men's Health Boston with leading researchers and experts from Harvard in the field of men's sexual health. Today, in the second half of the presentation, he will be discussing testosterone deficiency. Neil and Roos, it is a pleasure to have you, and now I will let you present on your respective topics. Over to you.
Larry, thank you very much. David, thanks. Pleasure to be have the opportunity to speak to our group today. This topic, my goal with this is really to destigmatize the issues around ED, around erectile dysfunction, and have people perceive the issue as we do with any organ pathology. As we age or, due to different disease entities, different organs don't work as well, whether it's your kidneys, your liver, your bowel. Well, your penis is no different. And the good news is that, there are treatments with modern medicine that we can do to improve function. And we don't have to accept the cards we're dealt, and there's things we can do. So let me continue now to explain that erectile dysfunction is hugely prevalent. And when I say that, half the men over 40 are experiencing some form of erectile dysfunction. And Roos will address the issues around low testosterone. And it simply is what you would think. It's when somebody feels that they're unable to achieve and maintain a satisfactory erection. What are the symptoms? Well, as you'd expect, difficult to get erections. The rigidity is less. Penetration is difficult or impossible. And difficult to maintain erections during sexual activity or until orgasm. And for some, erections cannot be achieved to any meaningful degree. It can have a major impact on men's self-esteem, It impacts the couples. It is sometimes the issues are of self-esteem, or feeling the sharing that anxiety. It's almost invariably experienced by both members of the couple, and can often, especially after prolonged time, have a major impact psychologically. So we want to reference some myths, and as Larry said, anybody with questions, Larry, if we can put out my cell phone, anybody can call me anytime, just to chat about any issues privately. Email is fine as well, but I am available to discuss the issues. So some misconceptions. It is not just a problem that we experience in our advanced age. Most commonly, I'm seeing men probably most commonly through their 40s and 50s. It does not have to be accepted as a normal part of aging. In other words, we have men that are seeing us in their 70s, 80s, 90s that have said, I've been fine till just recently. Yes, one way to treat ED is with the drugs like Viagra, Cialis, Levitra, and I'll come to that, but many people have concerns about the pills because you're taking a treatment that affects every cell in your body, is absorbing the medications. So there's a variety of side effects that people frequently experience. And another misconception is that maybe many have shared with me that it's brought on just from relationship problems or a lack of masculinity. And of course, these are also not valid. So as far as risk factors for ED, well, yes, aging, as with any organ decline with age, we commonly see that. And blood flow to the penis, which drives the quality of erection, is naturally compromised with age to some degree. Metabolic problems, we talk about high cholesterol, hypertension or high blood pressure, diabetes, which by a mechanism of having higher blood sugar, and how that causes inflammatory reaction to the small blood vessels, and how that compromises blood flow to the penis. So vascular causes, whether they come from diabetes or hypertension or high cholesterol, which plugs and reduces diameter of blood vessels, these metabolic causes are about 70% responsible for erectile dysfunction. Now, pornography is really a major cause, especially in younger people, and it's probably the most common cause of erectile dysfunction in younger people, and that is because there is actually a change in brain neurochemistry when you're watching repeatedly pornographic material, and it raises the threshold by which you will be able to get an erection, because quite simply, if people are used to seeing the kinds of scenes that are happening in pornographic materials that they may not be replicated at home, then their threshold for getting erection rises, and what is the old normal isn't working anymore to get aroused. Other important risk factors, smoking, which compromises vasculature, obesity as well, chronic substance or alcohol abuse, and of course, diet is a major issue, with reducing the amount of animal fat and protein, having more vegetarian nourishment is just a better for so many reasons. And as well, psychological causes of erectile dysfunction have to be mentioned. Depression, anxiety, chronic stress, which is why many say, meditation is another way of calming our neurochemistry to help with ED. We often discuss the concept of a canary in a coal mine, and that is that it's a warning for many to have an early onset of ED followed by ischemic heart disease. And what I mean is the same process going on in the coronary arteries is actually the same process going on in the small vessels of the penis. And in one study, we found that there is a significant increased likelihood of heart attack when you see this warning sign of ED. So as far as the mechanism, you can see here on your screen that there are two major pipes that run through the erect penis. We call it the corpus cavernosa, and then there's veins that are draining that blood flow. And the mechanism, there's also a third pipe on the bottom, which you can see houses the urethra. But the mechanism of erection is, of course, that those sinuses, those dual sinuses fill with blood, smooth muscle, etc., traps the blood, and the venous system proceeds in a way to occlude and retain the erection. Now, that whole process is obstructed with the pathology of ED. So when I talk to patients, I like to tell them, look, this isn't simple. This isn't easy to treat. However, let's talk about what you can do for yourself. So I explain to them, all the things we just mentioned. Change your diet, increase your exercise, both aerobic and weight resistance. And that'll help boost testosterone, which Roozbeh will talk about momentarily, how that interplays with erection. So outside of diet and exercise, the obvious lifestyle, reducing stress, meditation. And as far as, and we talked about pornography, shut that off as well. We talked about what your doctor can do for you. Well, we need to make sure, he or she needs to make sure your blood sugar is okay, your blood pressure is in control, your cholesterol levels are good, that you're getting the appropriate blood work and assessments to make sure nothing else is out of whack in your body to a major degree. And then the good news is there are treatments, and we talked about some of the short-term treatments like the pill, but there's also things that we focus on, like what's called acoustic shockwave. And I'll explain the mechanism of that. That is an energy that we apply to the penis over 12 visits, 15-minute visits, that stimulates the tissue to then become vascularized. More blood vessels, bigger blood vessels, pumping more blood to the penis. Platelet-rich plasma injection, which is taking your platelets, concentrating your own platelets, then injecting that in 5 spots with the tiniest of needle into the penis. Those platelets break open, break down, release protein products that actually rejuvenate the penis and enhance blood flow. Therefore, the more blood flow we're putting to your penis, the bigger, better, harder, stronger, longer lasting your erection is. We have another treatment called Trimix, an interesting combination of vasoactive chemicals. Vasoactive meaning they will impact the penis to engorge it with blood. And the actual process is incredibly simple. It just takes some training, and we have a Trimix training program where after a number of visits, myself and my nurse would train the patient on how to give this simple, virtually painless injection to give a very strong erection that can last up to an hour. And we titrate the medication dose to what their interest is as far as timing of the erection, how long they want it to last, etc. Also, sex therapy is an option. And that's important because men almost invariably, if they're having erectile dysfunction, are going to have performance anxiety. Last time they were in the situation, it didn't work. They're anxious. They're not sure if it's going to work again or not work. And sure enough, they're thinking about that instead of being engaged in the intimacy. And as a result, they're distracted and they're anxious. And a different neurological pathway is being engaged that is counter to what's required to get and maintain an erection. So if we look at some of the short and long-term solutions, well, we talked about these pills. What are some of the side effects? Well, many of you will know: flushing, upset stomach, headache, congestion, body aches, things like that. And it's interesting that, you know, Viagra, what a miracle discovery that it was developed for another purpose, and somebody found out that, man, this is a lot better of a drug and a lot more complex effects than we realized or designed it for. And but that is also why Viagra can impact in conditions of heart disease, people on nitrates, or in some blood pressure situations. Coming back to what is the longer lasting treatment options, well, this is our shockwave machine. It's got you can see a device, that blue cap device. There's a little water pocket in there that's placed in 5 spots in the penis. And you hear a little snapping sound every second as a pulse of energy painlessly is delivered that, again, stimulates blood flow to the penis. Let me see. I'm going to go back a slide. Right. Platelet-rich plasma, I alluded to. We have a bit more of the technicality on that. Your blood is taken out. It's put into a centrifuge, which spins the blood at high speed to separate the elements of the blood. And then we pull off the platelets and inject those, leaving, most of the red cells, white cells, etc. In regards to the technical aspects of the Trimix injection, it is about, if you can imagine what a milliliter looks like, this medicine is injecting usually somewhere between 0.1 and 0.5. It's the tiniest dose of medicine because it's a highly powerful agent. In regards to sex therapy, that is, we have associated a registered sex therapist, and those sessions are usually I don't know, most people, I think 4 to 6 sessions where you're given information and walked through how to practice techniques that would be useful before and during, to get your mind working with you instead of against you. So why did we set up this, the Men's Sexual Health Center? Well, we had a focused clinic for 25 years doing vasectomy and circumcision for all ages. And we were finding that a lot of our patient cohort had issues with erectile dysfunction and simply did not know where and how to get help. Many didn't want to be on medications. Many felt that, you know, to try to take a pill and time that 2 hours before and deal with some of the issues around that on long-term medicines. And so once we saw that, we went out and researched with input from the Harvard program and Dr. Morgenthaler, you know, what would be the best protocol to put together. And we liked the idea of combining a physiological and a psychological route because both are so critical. So we felt that the platelet plasma injections and the shockwave impacted physiologically. The sex therapy was wonderful for the psychological elements. And then we had the Trimix also, you know, for its biological effects. Over time, over the last couple of years, we realized there were many other conditions that men were suffering for that we would be reasonable to incorporate into our treatment program. So outside of erectile dysfunction, we realized there was a high prevalence of premature ejaculation, which is simply defined as, you know, ejaculating quicker than you wish to be. And for some men, that can be in 30 or 60 seconds. Peyronie's disease, we started a treatment program, which is essentially a curve in the penis that is probably had an original traumatic origin and now impedes functionally having intercourse because of the bend. Testosterone assessment is something that Roos will talk about in a moment. And of course, we continue to offer the procedures we've been doing for 25 years. So at this point, I guess we can take the questions, you know, once Roos has finished his presentation, and turn it over to Roos, who, as Larry's mentioned, you know, it's been terrific to work with Roos. He's really one of the most knowledgeable and competent family physicians that I've met. So it's a real pleasure to have him with us at Pollock Clinics.
Thank you so much. Hello, everybody. Thank you so much, Neil, Dr. Pollock, for a very lovely introduction. And I hope you guys can hear me well. If not, perfect. So as Dr. Pollock mentioned, erectile dysfunction is one of the most common form of sexual dysfunction. What probably gets less attention is the fact that people might be deficient in their testosterone. And Dr. Pollock, can you help me with changing the slide?
Yeah.
Thank you. So as you probably know, testosterone is the main sex hormone in men's body. It's mainly a cholesterol molecule, which is produced by certain cells called Leydig cells at the level of testes or testicles. And it's heavily regulated by hypothalamus and pituitary gland inside the brain. As we study testosterone more and more, we realize that although it's the primary sex hormone, so the main function seems to be helping with sexuality, it's actually, there are a lot of other psychological and physiological benefits from testosterone. It helps with muscle strength. It maintains bone health. I've had patients with dry skin who happen to go on testosterone therapy, and because they were low on testosterone, but they came back to me and they said that testosterone fixed my lifetime skin dryness. So it helps with keeping skin moist, and it helps with blood cell production. So what I usually say in my practice is there are older gentlemen with low-grade anemia, low blood count. They went through a barrage of investigations, and there was no objective findings for their anemia. And unfortunately, no one checked their testosterone, because usually these they have a low-grade testosterone level. Once we treat that, their anemia will get corrected as well. And of course, there are a lot of benefit for mood, for energy, for memory sharpness. So it's beyond just sexuality. As we probably know, our body starts producing testosterone around puberty, around 10, 12 years of age, and will continue producing testosterone for the rest of life. We happen to have the highest amount between 20, 30, late 30s, by early 40s, and in our some lucky fellow by early 50s or mid 50s, the level starts declining, and it usually declines at the level between 1 to 2% per year, and in some individual it could be as high as 4% per year. So that is pretty much a natural decline in testosterone level. But if we can have the next slide, please. But in addition to that natural decline in testosterone level, there are other pathological disease that can actually fuel into the decline and make it more extensive, make it a faster decline. So when we talk about the causes of testosterone deficiency, the easiest way is to think about primary cause and the secondary cause. And the easy way to remember them is primary cause is when testicles are not producing. The secondary cause is when testicle like to do the right thing, but there are other things outside the testicle that can cause interference with proper testosterone production. Going back to primary cause, of course, when people have disease of testicles, it could be testicular cancer, so they end up getting surgery and they remove the testicle. It could be a chronic infection of testicles, something we call orchitis, or it could be part of aggressive type aging when cells start dying super fast and quickly. And the secondary type, one of the most important places will be brain. People with multiple concussions, people with some benign neoplasm, like tumor of pituitary gland in the brain, or dysfunction in hypothalamus. In addition to that, we have metabolic disease that interfere with testosterone production, things like diabetes, obesity. If people are heavy drinkers, the alcohol use disorder is one of the causes of testosterone deficiency. People with chronic liver disease, chronic kidney disease, people with a very bad sleep pattern, or having a sleep apnea which is not treated. All of these things can also contribute to testosterone deficiency, but under the banner of secondary cause. Once the level declines below a certain level, people start having symptoms. And one of the early signs of testosterone deficiency is actually low sex drive, low libido, and more specifically, sexual fantasies and thoughts. So one of the first things people come and tell me, they tell me, we don't think about sex anymore. And that's probably one of the most sensitive and early signs of testosterone deficiency. But knowing that testosterone has a lot more benefits for body when it's low, then people start feeling fatigue, physical fatigue, low stamina. They get a little bit irritable. They get low mood. They think concentration is not as sharp as it used to be in the past, and ongoing fatigue. So as we see, the lack of sex or sexual desire is not the only sign or symptom of testosterone deficiency. Going back to what Dr. Pollock covered, Neil covered, when it comes to sex, a lot of people, like I guess myself, would think about it as a computer. In order for a computer to operate properly and effectively, we need a good hardware, but we also need a good software. The hardware part of the sexuality is erectile apparatus, pretty much, which Dr. Pollock covered perfectly, the whole erectile dysfunction or the abnormalities that can happen at the level of penis. Testosterone happens to be the software of sexuality. So it actually creates the conception of having sex, the desire to performance. And so to me and to a lot of people like myself and Dr. Pollock, it's equally important to have a proper testosterone amount. Thank you. So when people come to our practice and they're complaining of symptoms that match the symptoms of testosterone deficiency, we usually start screening them. And one of the screening tools we use is ADAM screening, which is a collection of 10 questions, pretty much asking 10 major symptoms of testosterone deficiency. So people will answer them. And if they happen to have a positive ADAM screening, then we have to confirm with their blood test that they actually have low testosterone. ADAM screening is a very good test, but very sensitive, but it doesn't have the specificity to confirm the diagnosis. So once we find these people who sound like low testosterone, we confirm that with a blood test. And when we do the blood test, we just go beyond just a simple testosterone level. We take a look at different forms of testosterone in our body, and also more comprehensive assessment to see if we can conclude the actual cause of testosterone deficiency. And I'm referring to, is it primary or secondary? Before I go through this slide, I just want to make a note here. Once we confirm testosterone is low, then our plan is to optimize it. And one of the things that I always want my patient to consider is a lot of things that Dr. Pollock mentioned, the lifestyle modification, because we know eating healthy, exercising, losing weight, proper sleep. If people have a sleep apnea, make sure that they get treated for sleep apnea, because all of these things can improve endogenous production of testosterone. But if the person has low T and does everything he can, modifiable things he can, but still testosterone is not optimized, then we have testosterone therapy. And I rarely use the term testosterone replacement therapy. I know it's widely being used, but the reason I don't like the term is the fact that we don't replace patients' testosterone. We just add what they're lacking. We top up their own testosterone with different formulations of testosterone. As you see, we have different forms. A lot of people have heard testosterone gels. Examples are Endergel or Testine. Some people use Endroderm, which is a transdermal patch. We also have oral pills, but I mean, no one prescribes oral pills anymore because of the high risk of hepatotoxicity, the side effects to the liver. Injectables such as testosterone sapinate or enanthate are very popular because they work very fast. And as of 2019, we had Natesto, which is an intranasal spray. The problem is they found a glitch in the pump, not the medication, but just the pump itself. So Health Canada removed Natesto from the market. They're going to fix the pump, and we're expecting Natesto to come back sometime, maybe end of 2021, maybe early 2022. That's why I still keep it on my on this slide, I guess. Thank you. So once we confirm that a person has low testosterone, and might be a candidate, the question is, it may not be the safe method of treatment for everybody. There are some contraindications for testosterone therapy. And as you see, if you happen to use testosterone, you open the pack of androgel or testosterone supinate injection, you open the monograph of the drug, and one of the first things you see is testosterone causes prostate cancer. So still, I keep it there as a contraindication, but I highlighted that one because I'm going to go back to it. There's something interesting about that. Of course, people with a history of breast cancer, as we know, probably between 0.4 to 1% of breast cancers are actually male. So if someone has it, we don't usually put them on testosterone therapy. Of course, if they have a very abnormal prostate exam or severely elevated PSA, which is a prostate test, prostate antigen in the blood, we don't put them on testosterone right away. If they have history of a lot of blood clots in their chest, in their legs, like DVTs or PEs, that might be considered a contraindication. And if they have a severe untreated sleep apnea, we'll like a sleep apnea to be treated first before we consider testosterone therapy. And of course, if they had heart attack and a stroke within the last 6 months, again, that may not be a very safe practice. We can always wait till they pretty much recover. They go over the first 6 months of recovery. And once people start testosterone therapy, and this is more related to younger people using testosterone, is the fact that testosterone therapy can suppress sperm count and sperm production because we are importing testosterone from outside. Sometimes testicles, the amount of testosterone production in patients' testicle will drop. As a result of that, the sperm count will drop as well. So that is another contraindication if they're planning to conceive in near future. It is considered to be a reversible side effect, meaning that if a guy goes on testosterone and the sperm count drops, once we stop testosterone, within the 6 months to 1 year, we see a meaningful return of the sperm count. But if a guy wants to conceive within the next few months, then it's probably not the wisest thing to do to put them on testosterone therapy. And same as again, the benefits of it, of course, and that slide still says TRT. Should be testosterone therapy. I apologize for that typo. It helps with sexual desire. It helps with, of course, libido, sex drive. A lot of men will come back to me and they say, I feel more energetic. My mood is getting better. Some people say, I'm less irritable. I sleep better. And overall, it helps with the global functionality of the patients. And of course, their partners through a better quality sex life. Sorry, Dr. Pollock, can we go to one slide before this?
Yep, hang on.
Thank you. So same as any other medication in medicine, it has some side effects. A common side effect is the fact that testosterone therapy can increase the concentration of blood, because as I mentioned earlier, it helps with blood production at the level of bone marrow. So in some individuals, they may get thick blood. So that's why we closely follow a patient's blood concentration once they go on testosterone therapy. It may cause some elevation of PSA, which is prostate antigen in our body. Some people will get acne or oily skin, but it's usually the type of people who have oily skin to begin with. If they have dry skin, that side effect is actually therapeutic because it makes their skin more moist. And some people may develop some hair loss. And through the same mechanism of reducing a sperm count, some individuals may also get some testicular atrophy. It doesn't happen to everybody, but in some cases, it might be, we may see it. The less common side effects or rare side effects, which is, I believe, a slide after this, and after this one. Thank you. Very rare side effects. And the reason I put it here is because if you open the monograph of the drug, you're going to see all of these things on the monograph as the kind of black box type the alarm, pretty much. Some people believe that it may cause heart attack, stroke. Some people believe that it may make the sleep apnea getting worse. But of course, they're talking about people who are not being treated for sleep apnea. And some people may feel breast sensitivity or pain. Less pain, more sensitivity. And of course, if they have super high levels of testosterone, they may start getting enlarged breast as well. There are some thoughts that it may cause blood clots and to cause a stroke. But if we go to next slide, Dr. Pollock, thank you. I just put this here to can we go back to slide before? One before this, please. Thank you. So I'm just putting here a few samples of the studies that have been done in the last few years about about testosterone therapy and potential effects and the side effects, and to see how much testosterone therapy is safe or unsafe. One of the first things that I mentioned is a lot of people believe it can cause prostate cancer. Yeah, and Dr. Pollock, can we go to the next slide, please? There is a paradox in the whole idea of testosterone causing prostate cancer. And the paradox is the fact that younger men happen to have the highest amount of testosterone, but they have the lowest rate of prostate cancer. As we get older, we end up with the lowest amount of testosterone as we get for older gentlemen, but they have the highest rate of prostate cancer. So the question is, if high amount of testosterone causes high rate of prostate cancer, isn't it true that we would have seen a lot of testosterone in older population, and which is not the case? So there's I guess a clinical observational paradox that unfortunately doesn't, not many people pay attention to that, or even if they see it, they don't discuss it with patients. Can we go to next slide, please? Thank you. Back in, I think, 2001, Dr. Morgentaler, Abe Morgentaler, 1996, Dr. Morgentaler at Harvard, they did a study. They collected a group of otherwise healthy men in 40s, 50s, 60s, and they checked their testosterone level, and they selected a group with low testosterone level, and they did prostate biopsy to see what is the incidence of pathology in these people with low with low testosterone level. What they realized that a big part of this cohort, the big part of these people with low testosterone, otherwise normal exam, otherwise normal PSA, normal prostate exam on the digital rectal exam, they realized that they have a significant amount of cancer cells in their prostate. So that kind of revolutionized the whole idea of testosterone is bad for prostate. And there are a school of thought now that people with low testosterone level in 40s and 50s, if we treat them with testosterone, it is protective against the risk of developing prostate cancer in their lifetime. And of course, back in 2017, a group of researchers, they did a meta-analysis of a lot of research. They pulled everything, all these studies that were testing the effect of testosterone on heart attack and stroke. They put all these data together, and they did a meta-analysis. And they realized that there is no compelling evidence to support the idea of testosterone causing blood clot, heart attack, or a stroke. So the reason I put all these research in the slides right after the side effect, I just want to tell you guys that unfortunately in medical community, there is a culture of panic when it comes to testosterone therapy. A lot of people don't really know why they're panicking, a lot of doctors, but in reality, the more we investigate, the more we realize it's not as angry or lethal as we used to think about testosterone back in maybe 30, 40 years ago. And this is I thought we're all dealing with COVID-19. We decided to smuggle one COVID-19 slide here that is just an observational study. They realized that there might be some correlation between the severity of COVID infection in men with low T. In other words, if a guy has low testosterone and happens to get COVID infection, seems to be, they may develop a more severe form of COVID infection compared to a guy with normal levels of testosterone. And I think I just stop here, and I'll be happy to take some questions.
We have our first question. I'm not sure who it's directed to, but I'll start with Roos. How safe are the gels?
Very safe. Gels, injections, transdermal patch, very safe if the person who's treating you is following the recommended guidelines. They're checking PSA level, blood counts, doing the due diligence, doing the physical exam, everything before they put you on the gel or any form of testosterone therapy, and they do close follow-ups, then we rarely see any problems coming out of testosterone therapy, and gel is just one format.
Does anybody else have questions for Roos or Neil?
And can you hear me, Larry?
Somebody's posed the following question. I believe that a man in a long-term marriage who has trouble getting an erection would have no trouble with the new sex partner who would stimulate him. Please comment.
And sorry, David, could I hear that one more time?
Somebody has asked that a man in a long-term marriage who has trouble getting an erection would have no trouble with a new sex partner who would stimulate him. Please comment.
Okay. Well, there's a lot going on there. And I think that's probably something, if he's interested and he and his long-term partner are interested in, preserving and healing, that they would go to counseling and they would see the sex therapist, and so a lot is questions come up about the dynamics and of the relationship, and so those are things have to be explored. I mean, what he's saying is that physiologically he's capable, and so it's really, I think, more of a psychodynamic issue that would be best explored in a more psychosocial context.
Neil, I think somebody has sent a question to you directly. Do you see that in the chat?
No.
Okay. Maybe they'll send it to me and then I'll read it. Here's another question. This is for Neil, Dr. Pollock. I eat a vegan diet and I believe in food as medicine. Do you suggest any particular foods that can contribute to stronger erections?
Well, it's a good question. I don't. I mean, I think if you're confident that you're having a balanced diet, and with nutrient-rich foods, then I think you're ticking that box. It's easier to counsel somebody who comes with the opposite sort of dietary position, but I don't think that we are that exquisitely tuned into to which micronutrients may or may not impact ED. So I don't have a cogent answer or recommendation there.
The next question says, I have a cyst on my testicle. I'm told that this is fairly common, touch sensitive, but apparently benign. Any comment?
Well, all that's true. I mean, most cysts are common. They're almost always benign. The worrisome indicators are evolution, growth of the cyst, because most of these cysts are stable over time. So if you have anything that's growing in your testicle, then it takes you to a higher risk, and it indicates that you need to have further evaluation, ultrasound, biopsy, physical examinations, discussions with your doctor.
Neil, a similar question. Are there parallel or equivalent conditions in women that we should be more aware of or sensitive to?
Well, having focused on men for 27 years, I don't know if I'm the best person to answer that. Is there a obstetrics gynecology talk coming up that we could defer that question?
We'll discuss them.
Okay.
Next question, can the side effects of due to testosterone be treated, counteracted? Is that for Roos?
I'll let Roos take a shot at that one. I don't hear Roos.
He's got to unmute himself.
Root, you're muted.
Can you hear me, guys?
Now we can.
Yeah.
Perfect. So going back to Avodart or the testosterone, the problem is none of the physicians will give more medication to counteract the side effect of the test right. The question is, does patient needs to be on it forever? And if no, then it should be stopped. And if they have stopped it, we're hoping that a lot of side effects will vanish, will go away. There are some concern about some ED, erectile dysfunction, that may come with these medications, 5-alpha reductase inhibitor medications such as the test right, and they believe the rate is very low, but unfortunately, if it happens, it might be irreversible. But I talked to a lot of colleagues, a lot of experts in the field. They're not super concerned about that because of the extremely low risk of that bad side effect happening. But I don't usually see people trying to add more medication in order to reverse some of the side effects of Avodart or the test right.
Roos, I think this question's for you also. I had a Leydig cell cancer and had a testicle removed about 25 years ago and had my testosterone levels tested about 8 years ago, and it was really low, but I did not end up doing any treatments, but now think I should address this again. Any advice?
My advice will be, it is a little bit tricky with Leydig cell tumors. And the reason is, we know these cells like testosterone. So there's always, it's a little bit different from prostate cancer. If the testicles are removed and there is no evidence of any cells, Leydig cells being left behind, then we can say that it's safe to go on it. But the problem is, I'm not sure if anyone can with certainty confirm that. So as a result of that, it might be a little bit tricky. So I strongly advise this gentleman to talk to the uro-oncologist who treated him for this type of cancer and get some expert opinion on that. In other words, I probably don't offer testosterone therapy with somebody with a history of Leydig cell carcinoma.
Anybody else have any questions?
All right, David, I think I'll hop in here. If there's no more questions, remember you can always send us your question. We'll pass it on to Neil or Roos or
Larry, do you want to give my cell phone if anybody wants to confidentially call me?
Actually, if you'd like, just put it up on the chat box, or you could read it out and we'll put it up for you if you like, Neil.
Okay, let's see if this works. Yeah, it's coming out here.
Okay.
It's 604-644-5775.
Try that and see if
that
it comes
goes.
up.
Yeah. That's my cell. Happy to speak to anybody.
Super.
Ooh, looks like it says privately. So did you see my phone number, Larry?
No, actually I didn't. I thought it was just hesitating. Why don't you call it out to me and I'll put it up there.
Okay, it's 604.
I'm looking for an all here, everyone. There we go. Okay, go.
604.
Right.
644.
Right.
5775.
Wonderful. There it is.
Perfect.
Neil and Roos, I want to thank you so much for doing this for us, for our group tonight. It was interesting, it was educational, and I would even say it was fascinating, actually. I learned a lot myself, personally. And most importantly, it involves men's health, men's sexual health. So you've done some good here, I think, tonight. It's not just an interesting topic, but it's an important topic. And you both handled it very well, by the way.
Thank you.
So yeah, it was terrific. It really was. And you know, the mark of a good presentation is always how many people drop off the participant list during the presentation. I always kind of follow that along, and I didn't see one person drop off. So that tells us everything, seriously.
Good.
Thank you, everyone, for coming.